Hello, I'm Dr. Marla Shapiro. One of the most difficult areas for us as physicians to discuss with patients is sex after menopause. Often there's this don't ask, don't tell on behalf of the physicians or the patient. And today, to help us with this, is Dr. Sheryl Kingsberg. Welcome, Sheryl.
Thank you for having me.
Sheryl is a professor in the Department of Reproductive Biology and Psychiatry at Case Western Reserve University School of Medicine, and she's a clinical psychologist and chief of the Division of Behavioral Medicine in the Department of OB-GYN and the McDonald Women's Hospital, University Hospital Case Medical Center. So let's start off with what is common in terms of problems in and around and after menopause.
Well, to start with, when you say common, you really mean common, because up to 43% of women will report having sexual problems, postmenopausal women included. When we talk about sexual dysfunction, that's about 11.5%. Well, that translates into millions of North American women suffering with sexual problems. The two most common problems for postmenopausal women are going to be loss of desire with distress and pain with sexual activity that's a result of genitourinary syndrome of menopause, or specifically vulvovaginal atrophy.
So we know that vulvovaginal atrophy will get progressively worse the further you are out from menopause, yet so many women are not on safe, available, effective treatments. Why is that?
Well, although I think gynecologists are pretty comfortable and other women's health practitioners are comfortable talking about vulvovaginal atrophy, I don't think they know to ask about it. I think there's an assumption that if women have symptoms, they're going to bring it up. But the fact is, number one, women do not associate VVA with menopause because it does happen a little bit after menopause because it gets progressively worse. Mm-hmm. They don't associate those symptoms with the loss of estrogen, so they don't even know to ask. They're also embarrassed to talk about it. You just said that don't ask, don't tell. Right. And women really are uncomfortable talking about anything sexual. They don't think it's appropriate to bring up with their healthcare provider.
So message one is we need to be doing a better history.
Yes, we need to be asking. We should assume if we have 64 million postmenopausal women, about 32 million of them are suffering with some symptoms of VVA. So we should be asking every single one of them.
Okay, now you talked about sexual desire.
I did.
And?
Well, it is the most prevalent sexual problem across all women across all ages, with about 11.5% of postmenopausal women meeting their criteria for having hypoactive sexual desire disorder, which is the persistent loss of all sexual interest. This is not just intermittent because you're having a bad day or some stress at work or you're mad at your partner. This is persistent, 6 months or longer, and most women will come in after several years of this.
Mm-hmm. And up until now, we haven't had any medications on the market, which is strikingly different than the male sexual market in terms of male sexual issues. So where have we gone, and why has it taken us so long to find effective treatments?
Well, there's been a little bit of a double standard in terms of how we perceive women's sexual health and men's sexual health. I have to say, before the PDE5 inhibitors were approved in 1998, when men came to their physicians and complained of sexual problems like erectile dysfunction, they were actually told it's all in their head. Once there was a treatment, it became all biologic. And that's not really accurate. For men, it's both psychological and biologic. But today, up until I think this year, the assumption had been if women complain of loss of desire, it's because they're in a bad relationship or because culture is telling them they should want to have sex when they should be left alone. But the fact is that this is distressing for women, and that we know that the cause of loss of desire is both psychological and biologic. There are neurobiologic factors that will impact sexual desire. So now, in 2015, we have the first approved FDA treatment for hypoactive sexual desire disorder, what you know of as flibanserin, which your patients will know the brand name is Addie.
And in terms of physicians prescribing this medication, what do they need to know about it?
Well, first they need to know they have to be certified. Mm-hmm. Unlike any of the male sexual dysfunction drugs, the FDA has required that there be certification, so it's not hard to do. They need to go to the Addie.com website, and they can read the REMS statement and learn a little bit about the medication, the side effects, how to prescribe it, what the appropriate patient is, because it's not for everybody. You know, as I said, desire is multifactorial, and so you want to be able to tease out, which you can. You don't have to be a sexual medicine expert to tease out what woman comes in with a pervasive loss of desire that is not related to her relationships or side effects of medicines or stress or an underlying medical condition, depression, for example, and what really is sort of a biologic loss of drive. And that's the kind of education you get. You get certified, and then you can prescribe to, at this point, premenopausal women is what it's indicated for. But we actually did the studies in postmenopausal women as well, and we've shown it to be effective and safe in postmenopausal women. There is a publication in Menopause called the Snowdrop Study that shows the data. And my hope is that soon after we start treating premenopausal women, the indication will hopefully go forward for postmenopausal women as well.
So the bottom line I'm hearing you for our clinicians who are listening to this is be an active part of the history and physical and guide and ask these questions.
Really, all you need to do is ask. And the worry for most clinicians out there is that if I ask, I'm going to be there all day. I have to tell you, if you just ask, tell me what your sexual concerns are, you will get an answer within 60 seconds. I promise no more. They don't really want to talk a whole lot about it either, but you need to ask, and don't be afraid that that's going to put you behind for your entire day. Women are waiting to be asked. They will appreciate you. Their perception of you as clinician goes way up, and it is very easy to assess and then offer treatment.
Thank you, Sheryl.
Thank you.